Okay. Well, thank you very much, Dave. It's wonderful to have Mr. Dave Booley and the patient committee, as you heard, because he's been, and especially Dave, has been the driving force behind this symposium, and it's wonderful that he is the leader in organizing, helping organize the symposium. The patients, one of the things the patients really wanted to learn, in addition to the MPNs, is what is new in hematology, because they all are familiar with the fact that the American Society of Hematology is meeting very soon, and this year it will be in Orlando, Florida, and Andy Schafer, who is a past president of that society, also the director of our MPN Center, has volunteered to give you an overview of what was important in hematology as he sees it in 2019, and what will be important in 2020. Andy?
Well, thank you very much. I thought my assignment from Dr. Silver for today would be really a very simple one, but I should have known better. And it was to present to you the highlights of last December's meeting of the American Society of Hematology concerning MPNs. The only problem has been that by my count last night, there were no less than 298 abstracts presented on MPN specifically at the ASH convention. And I have time to tell you only about 6 of them. So I've tried to choose very carefully the ones that I thought would have the highest impact clinically on our patients. So let's get going with them. Let me see if I can. Okay, so this is, okay. So this study, which was published over a decade ago by Vannucci and his colleagues, showed how the phenotype of polycythemia vera, in other words, the clinical manifestations of the disease, varied as a function of the JAK2 allele burden. And you can see in each of these 4 panels, on the upper left, the condition of having pruritus, in the upper right, having other systemic symptoms, in the lower left, having splenomegaly, and in the lower right, having a spleen larger than 15 centimeters. And you can see the JAK2 allele frequency quartiles on the x-axis. And you can see that there seemed to be a significant correlation between the occurrence of pruritus and having a high allele burden. There was perhaps some association with other systemic symptoms and allele burden. Splenomegaly and also spleens larger than 15 centimeters also seem to be correlated with allele burden. Now, what were the effects of the JAK2 allele burden in PV patients on their risk of having thrombosis at diagnosis, which is shown in the middle panel, at follow-up after diagnosis, which is shown on the bottom panel, and total thrombosis, both at diagnosis and follow-up shown on top. And it appeared here that there was some correlation between JAK2 allele burden and total thrombosis, and there needed to be more studies to actually verify that. The shortcomings of this study were the following. First of all, the sample size was relatively small. Secondly, no distinction was made between arterial thrombosis, in other words, myocardial infarction, stroke, or peripheral arterial thrombosis, as opposed to venous thrombosis like deep vein thrombosis and pulmonary embolism. And finally, a subsequent retrospective study seemed to contraindicate some of these results. So this is the first abstract that I want to tell you about from, again, the University of Florence group, which looked more vigorously on the JAK2 variant allele frequency, identifying patients with PV at high risk for venous thrombosis. Now, the reason this is important is that we now recognize that thrombosis and vascular complications are the leading causes of morbidity and mortality in PV, and in fact in the other MPNs. And the current risk stratification for thrombosis is based on predicting it by a function of age, being over 60 years old, and having a previous history of thrombosis. Those are the two simple factors that we traditionally look at for stratifying risk for future thrombosis. But since these were published, other risk factors have been considered and in fact are probably valid. And these include cardiovascular risk factors like smoking, obesity, hypertension, diabetes, et cetera, having a high white blood count, having leukocytosis, and again, it crept up, having a high JAK2 allele frequency. So this group in Florence had a database, or has a database, containing a total of 577 patients with JAK2 allele frequency determined within 3 years of their diagnosis and meeting WHO criteria for PV. All of these patients had information on thromboembolic events, the type and date of thrombosis they suffered at follow-up, thrombosis-free survival, and cardiovascular risk factors. And so when the data were analyzed, it turned out that the JAK2 allele frequency did not correlate with the occurrence of thrombosis at diagnosis, specifically at diagnosis. However, the occurrence of thrombosis at follow-up, with a median follow-up time of about 7 years, was significantly increased in patients with a JAK2 allele frequency of higher than 60%. In specifically low-risk PV patients, as currently defined by being less than 60 years old and having no previous history of thrombosis, factors that were found to be significantly associated with the occurrence of a first thrombotic event on follow-up included the JAK2 allele frequency of more than 60%, having cardiovascular risk factors, which is why we pay so much meticulous attention to these in following our patients, having bone marrow fibrosis, having splenomegaly, and constitutional symptoms. So the study indicates that conventionally defined high-risk PV patients who are over 60 and have previous thrombosis, who also have a JAK2 allele frequency of greater than 60%, suffer from an increased rate of thrombosis, especially venous thrombosis as opposed to arterial, and should be considered for more intensive antithrombotic prophylaxis and certainly for vigilance. Now, the second abstract is this one. It's the RUXAPEX study, and I'm presenting this both because the data are interesting, but also because the trial design was very interesting and something I think you should all know about. This is a multi-center Bayesian phase 1-2 adaptive randomized trial of the combination of ruxolitinib and pegylated interferon in patients with MPN-associated myelofibrosis. Now, what is an adaptive randomized trial? First of all, it is now considered to be an alternative to the classical randomized, double-blind, placebo-controlled clinical trials that still remain the gold standard for our clinical trials. And the validity of adaptive randomized trials has not been perfectly or uniformly accepted quite yet. Adaptive randomized trials have the ability to use accumulating data in real time as it accumulates in a trial to actually alter the trial as it goes along, thereby enabling a dynamic allocation to experimental arms and also enabling an earlier dropping of what appear to be ineffective arms. It is certainly more efficient and may actually turn out to increase the accrual of patients into trials. So I'll give you an example, a very simplified example of what I mean by this. If you take a disease like myelofibrosis and you want to have a randomized trial between drug A versus drug B, or a different dose of drug A, for example, you do that, but then you do an interim analysis, which is statistically significant, and in this case, it turns out that drug B was more effective and safer than drug A. So drug A drops out at this point, and then drug B is immediately put into competition with drug C, the third drug. And that goes into a randomized trial. And again, an interim analysis is done. And here again, for the sake of example, drug B wins again. And this time it's put up against drug D, and so on down the line. So this is a very dynamic sort of a trial. And the important thing about this, in addition to its trial design and more efficiency, is that the focus of adaptive randomization is the disease itself. It's not a particular drug or intervention. Now, given that, the Ruxapeg study was a multi-center trial to test ruxolitinib at doses of 10, 15, and 20 milligrams twice a day, plus interferon at doses of 45, 90, and 135 micrograms per week. The key inclusion criteria were diagnosis of MF by WHO criteria, having intermediate risk or high risk MF by IPSS criteria, which I'll get to later, the need for active therapy, and the presence of a driver mutation. The primary efficacy measure was a greater than 50% reduction in spleen size within 6 months, and secondary efficacy measures were reduction in bone marrow fibrosis, improvement in quality of life and reduction of symptoms, and event-free survival and overall survival. So the initial phase, which is what was presented at the meeting, was a randomization between the two best dose combinations that were really selected from phase 1. And this study is ongoing, but the initial data, so this is the first study to formally assess the safety and efficacy of this combination in MF patients who have never been previously exposed to either drug. And the initial reports are that the combinations tested showed no dose-limiting toxicity, confirming that this combination is generally well tolerated, and preliminary efficacy results that were presented are encouraging, including patients who received very low doses of both drugs. Now, moving on to this third abstract, which was actually presented at the ASH plenary session, where they select the top 6 or top 7 abstracts out of thousands that are submitted that are considered to be of the highest impact to the hematology community at large. And this specific one, I think, will have significant impact on our MPN patients. It's the Medalist trial. It's the results of a phase 3 randomized double-blind placebo-controlled study of LUSPATERCEPT to treat anemia in patients with very low or intermediate risk MDS who require red blood cell transfusions. As I'll mention, this study has actually been updated and published in Blood very recently, which now includes not only MDS patients, but also, as you can see, primary myelofibrosis patients, although a few of them. So we know that the anemia of myelofibrosis and also of MDS generally becomes resistant to available treatments, which are the erythropoiesis-stimulating agents, in a large percentage. About 70% of individuals become resistant to this form of treatment for the anemia. Agents like darbepoetin or Aranesp and epoetin, Procrit. And so for these individuals, the only available alternative has been multiple blood transfusions, red blood cell transfusions, and in some cases, actual transfusion dependency, which can lead to iron overload, shortened survival, and poor quality of life. Now, LUSPATERCEPT and its relative drug, SOTATERCEPT, have an interesting mechanism of action, which is quite unique, although not precisely worked out yet. They interfere with the TGF-beta signaling pathway and are therefore a new class of so-called erythroid or red blood cell maturation agents. They are administered subcutaneously, conveniently every 3 to 4 weeks. And this is what I mean by maturation agent. These 3 lines are the same, essentially, but they represent along in the longitudinal axis the maturation of red blood cell precursors in the bone marrow, starting with the first box, which shows the earliest stages of differentiation from stem cells. Then in the middle box in red, You can see the large nucleated red blood cell precursors become smaller, and eventually, at the end of the red box, ejecting their nuclei. And in the green box, you see what the mature red cells are when they actually go out in circulation. The erythropoiesis-stimulating agents, which we now use, are known to affect the early stage of red cell precursor production, which is in the first box. In other words, from stem cell differentiation. LUSPATERCEPT, on the other hand, binds multiple TGF-beta proteins to restore late-stage red cell maturation and stimulate that, as shown in the red box. So the site of action of these two classes of agents is different, and it could be predicted, perhaps, although we don't know yet, that taking both of these agents might have synergistic or at least additive effects in improving anemia and preventing red cell transfusions. In the phase 2 trial of MF patients alone, this is very early, this is in a very recent publication, 35% treated with SOTATERCEPT achieved red cell responses with good tolerance. The manufacturer Celgene had anticipated FDA approval for this drug this past summer. For reasons that are not clear, it was delayed, but it is expected that it will be approved by the FDA very shortly, as you can see from this advertisement from the company. Now, moving on to the next abstract, the DIPSS, D-I-P-S-S score, which is the Dynamic International Prognostic System for myelofibrosis, is well established, and it is a predictor for survival, overall survival of patients with MF. And one uses the variables of age, white blood count, hemoglobin, peripheral blood blasts, and constitutional symptoms down the left column, as you see, as the major determinants of prognosis. And each of these are weighted in different ways, either 1+ or 2+ if they're negative. And you see at the total score in the bottom is then added up, and you come up with whether stratification of low versus intermediate 1 versus intermediate 2 versus high risk MF. And in fact, the DIPSS system has been shown to be very effective in predicting survival. You see the yellow curve is the low risk group, the blue and black curves are intermediate, and the red curve is the high risk group of MF patients. However, the DIPSS prognostic model was never intended to predict the survival of patients with MF after bone marrow transplantation. And it also doesn't use any molecular parameters of disease in its scoring system. As I mentioned before, the only parameters DIPSS uses are age, white count, hemoglobin, peripheral blasts, and constitutional symptoms. So with this in mind, these investigators from Hamburg presented this abstract, which was a comprehensive clinical molecular transplant risk model for myelofibrosis in patients undergoing allogeneic stem cell transplant. And they used this newer model, the MYSEC-PM model, prognostic model, which is somewhat similar to the DIPSS model, but is different, and particularly different in that it introduces for the first time a molecular marker, which is the CALR mutation, as you can see on the left, with the unmutated CALR gene being actually a negative prognostic factor, and having a mutated CALR gene being a favorable one. It didn't use any other molecular markers at this point, but you see again the total scores add up, and they do correlate, like the DIPSS score, with median survival. But then they looked at whether or not this model actually compares favorably with the DIPSS model in terms of post-bone marrow transplant survival. So this, in their group, is the DIPSS model, and you can see the curves, the survival curves of overall survival post-transplantation. It looks like they're separated out pretty well, with the lowest risk being the solid line on the top. But in actual fact, these are not statistically significant. The p-value is 0.3. And when this group actually applied the MYSEC-PM model, the newer model, specifically for post-transplant patients, you could separate out these various levels of risk much more clearly and they were significant with a p-value of 0.05. So the conclusions were that incorporating transplant-related as well as clinical and mutational information together with this MYSEC-PM prognostic model may actually enhance risk stratification to properly select patients for allogeneic stem cell transplant. We do need, I think, to be aware of the limitations of this study. The prognostic capability of this scoring system does remain modest. Of all the factors that are included in the MYSEC-PM scoring system, only the CALR mutation status and age turned out to be significant independent factors for survival following transplant when the data were subjected to multivariable analysis. But I think the study does suggest that in the near future, a more refined and comprehensive scoring system that will include more molecular data will carry better predictive value for bone marrow transplantation, almost certainly incorporating these different things. It will also improve our counseling of patients with respect to post-transplant outcomes, specifically in this case in post-PV and post-ET myelofibrosis undergoing transplant. Now, getting down to the last two, this study from Denmark was a very important one and has been the basis of others that are being designed. And this had to do with the safety and efficacy of this combination therapy of interferon plus ruxolitinib in PVERA and myelofibrosis. And the first question I guess we have to ask is whether or not there is any rationale for even trying this combination. And the answer to that is definitely yes. And we know the following facts. We know that patients with MPNs in general have a systemic inflammatory condition to a greater or lesser extent. It's a systemic inflammatory state. We also know that both from in vitro studies and from animal studies that the effectiveness of interferon on the mutant stem cells is blunted when there is a coexisting systemic inflammatory state. Now, ruxolitinib, we know, amongst other things, is a very potent anti-inflammatory agent. So it's logical to therefore conclude that ruxolitinib, by lowering the systemic inflammatory condition of a patient with MPN, might actually improve the efficacy of interferon. And it may even allow lower doses of interferon to be used. So this was a prospective, open-label, single-arm phase 2 study. 51 patients with PV or lower intermediate risk MF, including post-PV MF and post-ET MF, were used. These were the primary endpoints: complete remission, partial remission at 12 and 24 months, and these were the secondary endpoints. This combination therapy was shown to actually improve overall response, as shown by the height of the bars. You can see here over the first 12 months, and actually shown to actually improve complete hematologic response, as shown by the dark fractions of these bars up to 12 months. This was in PVERA, and this is in myelofibrosis patients, which looks to be quite similar. No unexpected toxicities were reported. At 12 months, there was a decline. I didn't mention this. There was a decline in JAK2 allele frequency in 88% of the PV patients, with a median reduction of 47% to 23%. And at 12 months, there was also a decline in the JAK2 allele frequency in 83% of the myelofibrosis patients, with a median reduction of 45%, 18%. And very importantly, approximately 80 to 90% of patients who were not initially in complete hematologic remission saw complete hematologic remission at some time during the treatment. Now, finally, let me show you this abstract, which has also been updated in a recent publication, having to do with pegylated interferon for PVERA and ET in those who are resistant or intolerant to hydroxyurea from the MDP RC111 multicenter trial investigators. And here again, partial response, complete response, and overall response rates were evaluated at 12 months using pegylated interferon alpha-2 in PV and ET patients who had been resistant or intolerant of hydroxyurea. 115 patients were enrolled, 77 were intolerant, 37 were resistant to hydroxyurea. The mean weekly doses of interferon that were given in this study were 103 micrograms for ET and 129 micrograms weekly for PV. In PV patients, the overall response rate, which is the complete response rate plus the partial response rate, at 12 months was seen in 60% compared to the null hypothesis rate of 35%. The null hypothesis is actually, in a clinical trial, attempts to make a significant statistical comparison with what would be expected with standard therapy. And in ET patients, again, the overall response rate at 12 months was seen in 69% compared to the null hypothesis rate of 35%. And as you would expect, complete response rates were higher in the CALR mutated patients. This, again, shows the graphic representation of what I just said. So I think in conclusion, I think in the setting of hydroxyurea resistance or intolerance, pegylated interferon has demonstrated activity in high-risk ET and PV patients and should be considered an effective therapeutic choice. Proper patient selection, gradual dose escalation, and prompt evaluation of pegylated interferon in these patients will be extremely important. And whether pegylated interferon or ruxolitinib or a combination of those two, as I mentioned before, is most effective therapy in these specific PV and ET patients will require additional studies. So I'll skip over these last two slides. That's it.
So Andy, please come back. So Dave and I neglected to mention that for the patients, we want you to write your questions down on index cards, which Barbara and her staff will circulate, because we will have a panel discussion later on this afternoon to answer all patient questions. But then this morning, we are not doing that. We're having the investigators ask the speakers questions if they wish. Andy, thank you very much for that excellent presentation. We have Dr. Verstovsek, who published on SOTATERCEPT from MD Anderson. Serge, would you tell us your experience with this very interesting drug? And I might say none of this has been rehearsed, so Dr. Schafer didn't know that Dr. Verstovsek, he knows he's published it. And then we're going to come to Dr. Hasselbach.
One by one, I guess. So good morning, everybody, and thank you very much for having me here. A very nice summary. Thank you so much for that informative presentation. And you are right, the LUSPATERCEPT and SOTATERCEPT, two similar drugs, are important to follow in the development as medications for anemia. As you point out, anemia is a major problem in myelofibrosis, and having LUSPATERCEPT as an agent for a cousin to myelofibrosis, myelodysplastic syndrome, make us wonder whether it should be and whether it's active in myelofibrosis itself. The study with LUSPATERCEPT is underway. This is a multi-center global study with multiple different arms to see whether this drug is active in myelofibrosis. But as you eloquently explained, we do have some preliminary results. And this is from my own center at MD Anderson in Houston, our own study, with SOTATERCEPT, a cousin to LUSPATERCEPT, where in about 35 to 40% of the patients we do see significant improvement in red blood cell count, elimination of transfusion dependency, and on top of it, the drug is really safe. It's given as an injection under the skin every 3 weeks. In the earlier studies in some other conditions, there were reports of increasing high blood pressure. We didn't see that much at all, and no other side effects. So it's pretty exciting to see from multiple angles that we are in a situation where possibly we will have in the near future a medication that would help us manage anemia. But we'll see. The studies are underway.
But what, it's only 30% that you said?
This is in the paper that was, I think, published.
Right, so about 35% to 40% of the patients with myelofibrosis respond to SOTATERCEPT. They may or may not be on ruxolitinib, the JAK inhibitor, at the same time, doesn't really matter. So it may be useful if we are lucky to have this drug, lucky is a good word, to have this drug active enough for further drug development, then it will be used across the board for any patients that have anemia with myelofibrosis.
No, I think that's correct. I mean, it looks very, very promising. And I'm sure you thought about the possibility of actually combining it, if needed, with an erythropoiesis-stimulating agent, because they work at different sites.
Absolutely. Not at the moment yet. The interest is to see how active these major medications are on their own and in combination with the major medication that we use, ruxolitinib, for spleen and symptoms, because with the combination we would be covering symptoms, spleen, and the anemia between the two drugs. In the future, to enhance the anemia response, absolutely, combination with erythropoietin-stimulating agents makes absolute sense.
Do you have any information why this drug has not appeared on the market yet, or has it been FDA approved as yet?
I don't know.
No. Okay, no one knows.
I think it really will be approved. I mean,
So you also cited this interferon ruxolitinib combination, and we have one of the co-authors of that study, Dr. Hasselbach from Denmark, who I will introduce very shortly. Hans, do you want to comment on Dr. Schafer's presentation?
Thank you. Yes, we have the 24 months data showing actually the same very promising results from the 24 months data, which is in review in Hematologica and hopefully soon be published. So it is a good combination, and we are able to rescue those patients not tolerating interferon. That is a very important remark, I think, who otherwise will not tolerate interferon very well.
great. No, it's terrific, and I think many of us seeing MPN patients are already beginning to use this combination, and even using the lowest doses of both, we're seeing objective responses.
I can actually.
And speak in the microphone.
I can actually.
Can you hear Dr. Hasselbach?
I can actually add a comment to this, because we have launched a study on 25 newly diagnosed PV patients, and just to emphasize that we can reduce the dosage. So Pegasus 45 microgram every second week, and only Jakavi 5 milligram twice daily. Otherwise, we induce neutropenia.
Thank you very much.